seminar series. And my name is Janet Turan. I'm one of the team leading this scientific working group, along with Dr. Michael Vinacourt, who is here with us, Dr. Rena Patel, and Dr. Katya Bruxford. And so just to kick us off, I'm going to share just a few slides, introduction, before we get into our main speakers of today. Let's see if I can manage to do this well. Okay, can you see my slides?
Yeah, we can see them.
Yes, great. Okay, so this is a new scientific working group within the UAB CFAR, and we are excited to be sort of trying to promote more of what we're calling, and what the field is calling, global health reciprocal innovation. So bi-directional and iterative, really partnership exchange of technology, methodology, or processes between low and middle income countries and high income countries, or sometimes between more than one low and middle income country. And the goal of this is to really address shared challenges around health. And so we're excited that I wonder, do you see all right, just want to make sure you see the slide mode. Oops. Can you see it now or not? Did I just do something bad?
You see the title slide still.
Still, okay. And this one now, we're good? Okay. So here, do you see the second slide?
No, we're still on the title slide.
Oh, shoot, sorry.
It's all
I knew
right.
something like this would happen. There's something going on, right? Quite odd with my...
Janet, now we see your second slide about global health reciprocal.
Okay, okay, thank you. That's where I wanted to be. And so here's just the overview, and our speakers are going to share much more with us about this concept. And here, we'll share these slides later, but here you can also see the link to our website that has been developed for global health reciprocal innovation news and resources. And so this seminar series is co-sponsored by the UAB Mary Hirsink Institute for Global Health. And we're kicking off with this initial presentation, which is really going to give us some sort of framing and basic background around reciprocal innovation, and also allow us to learn more about the things that AMPATH and Indiana University have been doing in this space. Then on September, October, we're planning to have a panel featuring 3 different GHRI projects. And then again, another one in January and February, we'll feature some more of these projects. And then finally, maybe wrap up this with a seminar on development and sustainment of effective partnerships for GHRI. So one thing we wanted to make a plug for just very quickly is that we do have an RFA out for pilot awards in this area. And this is a exciting and opportunity now that we are able to sponsor some pilot awards of up to $50,000 a year, up to 2 years. And this has just been released recently, the end of last month. The letter of intent is due on July 17th. Followed by deadlines for full proposals and applications, etc. So if you are excited by this seminar and are interested in applying for some funding on this, please, there's a link here for the RFA and the submission information. And we do have some partnership from other organizations at UAB in this as well. And so with that quick plug, and please do reach out to us for more information, I would like to introduce our speakers for today. And so we have three speakers that are going to talk to us about the global health reciprocal innovation sort of frameworks and concepts and the experience of Indiana University and also AMPATH program in Kenya. So we have Dr. Jeff Churchill Kiplagat, or Chiri, who is Director of Research at AMPATH and has been really one of the leads in this reciprocal innovation work. And Dr. Laura Rule, who is an assistant clinical professor at IU and the director of their reciprocal innovation program, and has also worked in Kenya for, I think, over 10 years and is very helping to lead this program along with AMPATH colleagues. And then Michael Scanlon is a health policy scholar at Indiana University, working together closely with this group on reciprocal innovation, and has also spent many years working in Kenya and together with AMPATH and other colleagues. So we're very happy to welcome you here, and we'll love to hear what you have to share with us today, and we'll hope to have some time for questions and discussion at the end. Thank you. I'll leave it over to you to share and take it away.
Sure enough. Allow me to switch off my video just in case my internet doesn't work. But yes, we want to thank you so much, Janet, for that kind introduction, and mention that we are really honored as a team from AMPATH, representing Moy University and Indiana University, to join you today to introduce Indiana University's Reciprocal Innovation Program as part of your GHRI Scientific Working Group seminar series. As Laura gets that up, before diving into the concept and the application of RI, I want to first provide the history and institutional context that gave rise to this program, specifically the AMPATH partnership in Kenya, which really has been foundational to Indiana University's approach to global health and innovation. So AMPATH, in short, what we term as academic model providing access to healthcare, is a result of a long-standing global academic partnership that began in 1989, when Indiana University in the US and Moy University in Eldoret, Kenya, launched a collaborative relationship that was really focused more on education and clinical training. But the partnership formally evolved into the now what we call AMPATH in 2001, when Indiana University and Moy University, along with Moy Teaching and Referral Hospital and a consortium of North American universities, came together with a shared vision to build a model of care that is integrated, holistic, and anchored in public healthcare systems in Kenya. Today, AMPATH has grown into a robust tripartite model that blends both care, education, and research, and engages with over a dozen academic institutions globally with active partnership. The program has achieved a lot over the past 3 decades. Basically, it's been able to demonstrate the power of long-term, equity-driven academic partnership to strengthen care, build capacity, and drive research. It currently supports Kenya's public health system, serving a population of 24 million people in Western Kenya. A program that also supports HIV care services for more than 110,000 individuals, has achieved or has lowered mother-to-child transmission rates to less than 4%. And it is a partnership that has transformed health systems for oncology, for chronic diseases, for mental health, and has been platform for pilot testing some of the national health financing models like UHC that is being piloted within the country here in Kenya. In education, the AMPAT has trained more than 2,000 students and residents, empowered more than 1,000 community health workers, and over 100 faculty members in collaborative research. In research realm, AMPAT has secured over $250 million in research funding and even produced out of this more than 1,500 peer-reviewed publications. Next slide. Laura, next slide. Thank you. AMPAT continues to dream big and make even bolder visions. After more than 34 years, AMPAT is evolving and it's currently replicating its success in other settings. In Mexico, we have Puebla, we have Tamale in Ghana, and also Dolikal in Nepal. Each of these implementations is shaped by local priorities and led by host country institutions in close partnership with international academic collaborators and the Ministries of Health within these specific countries. Next slide. Great, and this is really the core of where we are headed to in terms of reciprocal innovation. Allow me to highlight the core principles that make AMPAT not only successful, but also uniquely positioned to drive innovation in a reciprocal way. One of the key principles is the shared belief that health is a human right and must be addressed holistically, where partners come together and work towards this one focus, that health, and basically it being a fundamental right, should be provided to all. Two is the accountability to community needs, where programs are designed based on the needs identified by the host partners, making them locally accountable and, in that aspect, also sustainable. Long-term engagement and equitable partnerships that commit to building a mutual benefit to both partners across all, within the globe, whether it's in Nepal, whether it's in the US, in Kenya, Ghana, and also Mexico. And then the relationships that are built that basically, in a counterpart way. And you note that within the AMPAT program, leadership rests more often within the host institution, and this allows to build the trust and also the local ownership. We've leveraged a lot on the institution's strengths and also within the health systems in the specific countries to promote sustainable impact. AMPAT continues to foster learning health ecosystem where research, capacity building for health workforce, and care delivery are deeply interconnected, and that we collectively and are deliberately putting ways that complement and recognize that no single partner all the answers. And importantly, the model of AMPAT allows space for us to learn from mistakes, adapt, and also improve from the mistakes that we make. These principles have made AMPAT a platform for collective innovation, and it's from this platform that the concept of reciprocal innovation has emerged. Allow me to usher in my colleague Michael to take you through now the RI program within the IU. Welcome, Michael.
Sure, thanks, Jerry. I think Janet cited this definition in the introduction, and I think as we've developed the program and learned along the way, we very much sort of considered this an evolving definition in some ways. And maybe even more important than the definition is the sort of key components that I think we really think of when we think of reciprocal innovation and as driving a reciprocal innovation process or approach. And of course, not always as linear as this figure would suggest, but the stages we've kind of identified as part of an RI process include identifying sort of shared priorities within a sort of collaborative and equitable partnership. Oops, sorry, Laura, can you go back to there we go. And then co-developing interventions and solutions, moving to implementation and evaluation of those innovations, sharing those innovations and learnings across settings, and then refining, scaling in one setting, and then potential for adaptation in another. Next slide, Laura. So in 2018, we established a reciprocal innovation program under our Indiana CTSI, which brings together Indiana University, Purdue University, and Notre Dame. But this was really spearheaded by a group of longtime AMPATH collaborators. And we were really trying to think about how we create a program that is really intentional about supporting and facilitating research and learnings and adaptation across Indiana and Kenya. So the goal of the program was to really start to build some of this sort of programmatic infrastructure to facilitate and grow reciprocal innovation. And from the start, the program has had three primary components or sort of projects within it. The first is to host what we called stakeholder workshops, very similar to this. The second was an RI grants program. And then the final part of the project was a learning and dissemination platform. So I'll very briefly talk about each one of these. One of the first and I think most important parts of the RI program was these stakeholder meetings, which we held every year and rotated them from being held in Indiana and in Eldoret in Kenya, where our AMPATH partnership is based. And the purpose of these was to really bring together folks who might be interested in this idea of RI. This included researchers, practitioners, funders. We had early engagement and support from Fogarty. And really as a forum to talk about RI, how we might engage in this work together and what might be some of the shared health challenges and projects that would be ripe for reciprocal innovation. And these stakeholder meetings really informed our annual call for proposals for the grants program. Next slide. So the grants program has had two types of grants, a planning grant and a demonstration grant. The planning grant was meant to really support partnership building and the early stages of project development. And this was one of our learnings from many of the stakeholder meetings, was that investigators really needed funding to support building these types of international teams and creating these relationships to support reciprocal innovation, and that this type of funding was really hard to find. So the planning grants are worth up to $10,000 for 1 year to support really partnership building and sort of trust building within these teams. And then the demonstration grants are to support sort of initial testing and adaptation and implementation of reciprocal innovation projects. And these are up to $50,000 for 2 years. So we've awarded 16 of these grants since the grants program started. On the right, you can see where these projects have taken place. This figure includes some awards that were part of an earlier sort of iteration of this program before we transitioned to RI. But the main takeaway is the same, and that's that the majority of these grants are continuing to support work with AMPATH colleagues in Kenya. And so that Indiana-Kenya sort of pipeline remains really, really strong. And a few years ago, we did a small survey of investigators who've received RI grants and found very positive results in terms of the RI grants leading to either new or deepened partnerships, and then subsequent grant applications with their teams as well. Slide, Laura. One of the other objectives of the program was to build some sort of platform for learning and dissemination about reciprocal innovation. So we do have what we've called an innovation exchange that includes some resources about reciprocal innovation, some recordings of our previous stakeholder meetings, and then a database of funded RI projects, which you can see to the right. We had plans to expand this platform, make it more interactive, maybe host things like echoes. But unfortunately, a grant that we had applied for to do some of this work was not funded. So we're still thinking about ways to sort of revamp some of this learning and engagement platform to be more engaging and interactive. So definitely a work in progress there. Next slide, Laura. And then this is my final slide. Lots of challenges and learnings along the way. I won't go through all of these, but maybe just to highlight a few that may prompt some of our discussion later. I think first, and maybe not surprising to anyone on this call, we were challenged in the research world and at institutions with sort of the siloed camps between those who focused on domestic work in the U.S. Versus those who were in the global health world. And maybe even a little skepticism and hesitation from those doing sort of community engaged work in the US about what global health investigators and teams could bring to the table. I think we've also continued to find it challenging at times to sort of maintain true reciprocity in projects that are more US based and focused, and for global investigators to participate as full partners in that work. And I think that there are many reasons for that. In terms of lessons learned, I think going back to the point I made earlier about having funds to support relationship building and project co-creation, this was really important for our program, especially as we launched into this sort of new space, and it's really led to some great global partnerships working in interesting areas. And then finally, in terms of next steps, we are moving forward with building out some of the program infrastructure into what we're calling a sort of reciprocal innovation hub with new partners in Indiana. And as Chiri mentioned, we have emerging partnerships in Nepal, Ghana, and Mexico under the AMPATH umbrella. Also, as I mentioned, we had an NIH proposal to do some of this work that we heard this month was not funded. Again, probably not surprising to anyone on this call. But we are moving forward with some emerging partnerships in Indiana, especially with immigrant health and community organizations. And I think this is a really good example of some of the ongoing RI work in action. So I will pass it to Laura to talk about some of this work. Thanks.
Thanks, Michael. And thanks for the invitation here today. So as Michael said, and as you saw on the map, a lot of our pilot or demonstration and planning grant funding really was based in the LMIC, and we are the next focus is really how to take. Now we have some of these partnerships that are focused on reciprocal innovation, but that next step of how to get implementation in the US, bring our LMIC partners with us, has been the hurdle. And so what we've been focusing on the last couple years is really kind of making some models to make that happen. I think the proposal we had to NIH was really to help with the academic infrastructure to make this happen and set up these hubs and be really deliberate about it. But fortunately, where my focus has been throughout my time living in Kenya has really been in the implementation space. And so right now we're really putting our heads down and trying to implement some projects that really help model reciprocal innovation and learn what we can from those projects. And so one of the greatest challenges in the last 2 years in doing that, as Michael mentions, is that we have these robust global health partnerships with both global health and North American investigators and LMIC investigators, but we are completely missing local partners, local community partners here in Indiana, and that's a piece that those partnerships take a long time to build, and we don't want them to be centered around one project. We want them to be centered around the whole vision and program, and so that's what we've been doing, is kind of almost making an Ampath Indiana and trying to build these partnerships. We have done this with many listening sessions with all the different community partners. We've learned a lot in that time, in that, you know, you can say reciprocal innovation, global learning, global local, all the different terms, right? Those don't necessarily mean much to the community partners when you're talking to them. Even academic partners that are based doing local research here, health equity research here in the US, it doesn't help them understand either. So we've really actually don't use the terms very much. We just talk about kind of the work we want, what we hear about their challenges, what they want to do, and then we try to draw examples from work we've done in Kenya and how we could try to move forward together, and less on the terminology of things, which sounds obvious, but it took me a while to learn. But I think it was because I was new to work here in Indiana and really did all my work overseas. And then once we've established those partnerships, we've gone about this doing community health assessments together, understanding the challenges that exist for them, and identifying gaps that are important to the community and to the partner, and then trying to figure out how we can use our learnings from globally with our global partners to make some impact. This has brought us to 2 areas. Immigrant and newcomer health has become a real focus in this, where we're trying to find gaps and where there's not too many academic health equity investigators in the space. And then rural health is our other area. I'm going to focus on one just because of time today, but we're really looking to develop both of these areas. Sorry. As you've seen, steering a slide deck is not my skill set. We have decided first in our newcomer health portfolio to focus in on the Haitian community here in Indianapolis. And this was through all this process that I've kind of described. What we found is the community in Indianapolis is the similar community to what you've heard on the news in Ohio. All of these different small town Indiana and Ohio and Illinois communities are kind of very interrelated and linked in the Haitian community, and and much of it is due to the staffing agencies that are placing the workers in these areas, and then families follow. Because they're very new to the Midwest, there hasn't been a lot of focus on how to improve their health. And what we're finding is we can actually attribute worsening outcomes due to this population, especially in infant mortality and maternal morbidity. And so since my focus traditionally has been in maternal child health, that's been a big focus for us. And we've been able to establish some really good Haitian partners. Since there were so many players in this space, we decided to develop a Haitian Health Coalition for all of Indiana as our first step to try and just help be the glue and help get people working together because things do seem very fragmented. Many of the Haitian community partners are acting, they have the direct connection to the Haitian community, they have the trust. But their service delivery, they're really just outsourcing and referring people. But they're referring people out to organizations that don't have capacity with language services to care for people that speak Spanish. Well, Spanish, yes, but Haitian Creole. What we find is this population can sometimes speak both because of their time in South America and Central America coming up through their immigration pathway. And so we're trying to connect all those different partners and having one solid partner we've learned is probably not feasible in the way we've done things in Kenya. One or two key partners. I think we need to have many partnerships to be able to draw in, bring people together to really impact care. And so this coalition has been the first step at doing this. So I'm going to jump to just a project that we have about 3 or 4 projects that we're kind of trying to make happen in an intentional way with reciprocal innovation in this space, in this newcomer health space. But one project that I've co-developed and led with some very close friends and colleagues in Kenya is called Chamas for Change. The dean of Moi University in Kenya, and then an OB-GYN in Vancouver. We all developed this model in about 2012, and we've been able to scale it up through Western Kenya and been able to do cluster randomized controlled studies to show its effectiveness and really find that it's something that can be sustained in the public system. And so it's drawing on all the successes of like centering pregnancy and facility-based group care, but moving those groups from facilities to communities. We did try in the early days a facility-based model, and it just didn't work as well in Kenya or in rural Western Kenya where we were. But the goals are to bring women together, give them that peer support, and then layer on what they need in life and what we want to impact. And so our interests are health, but their interests are the well-being of their families, most specifically education and economics. And so we packaged it all together in these community groups to deliver healthcare that starts in pregnancy and goes through the 3rd year of the child's life, and then embed different components to help them help empower women to really take ownership over their families' lives and health. And so these groups are in Kenya structured with two community health workers that share the responsibility of each group. We have 2 postmenopausal mentors in each group, and then the group of pregnant women to start, and then it goes that 3 years. And then we have all the different content of the health. We have a lot of social topics, and we try to do it all facilitation, no didactics. It's women teaching women about both health and social with just someone there monitoring that it's correct information. And then a financial literacy and agribusiness package with the option of participating in microfinance. So that's the Kenyan model. But we're working on like, what does that model look like in the US, and how do we make it happen while keeping that connection with Kenya and with the staff and leadership in Kenya, but make it something that takes those key tenets of peer support, health focus, and then empowerment pieces for women, but meets the needs of newcomer populations here in Indianapolis. And so we've made a lot of progress. We're getting ready to launch. We're really excited. We have a Haitian community liaison and a new community health worker who speaks 4 languages, who will lead our first groups. We've sent that team to Kenya to co-develop it with the Kenyan team on what would Kenyans think this might look like in the US. With the help of the Haitian American and then the Haitian immigrant working with that team. And then we are in the process of training our CHW. Obviously, the trainings that we do in Kenya aren't necessarily the trainings that need to happen here. And so we're drawing on a lot of different curricula in the US to do that training, but then also supplementing it with some of the key pieces of our Kenyan training. We are developing all sorts of health system kind of navigation pieces. We're using human-centered design to help us do that. So to understand from Haitian women, what do they need help navigating, what's confusing about the health system. And then now the next step of that human-centered design is taking the women with kind of the traditional health navigators in the health system to see like what could we create to make that really dedicated to newcomer populations. And then finally, this empowerment package. What does that look like? In Kenya, it's the traditional global health, microfinance, agribusiness, financial literacy. But in the U.S., it's starting to look very different. It's how do we embed ESL classes in our groups? How do we do job readiness training or help people finish their GEDs within the groups? Immigration assistance, obviously, during this time since the newcomer population is going to be a huge focus of it. And then an area that I think any mother knows is that unless you can solve the childcare piece, women can't move forward with earning income and meeting their goals. And so I think eventually we would like to tackle that in some way, but that probably is going to come after these other 3 areas. Finally, to that kind of piece of how do we include our Kenyan colleagues and how do we get we don't just want to be that bridge between the global health investigators on the team, Chiri, myself, Michael. We don't want to be that bridge. We want our Kenyan team to feel connected to our local team in Indiana. Because that's where the innovation is going to happen, is those 2 people connecting. It's not us. We can bring ideas, but I think that those relationships are going to be what may take that next step to bring back to Kenya something new and some idea. And so we're trying to kind of over the pilot bring in different members of the team to be able to participate in the process. But that takes money and people's time and paying for travel sometimes is like, you have to really think through, is this just for fun or is this helping the project? And so we're trying to be thoughtful about that as well and have obviously some virtual components as well to keep people engaged and connected. So hopefully I haven't gone over on time because really we want to have time to talk about any questions you all might have or comments or anything. So just our typical acknowledgements. And again, thank you so much for inviting us to speak today.
Well, and thank you so much, for sharing this with us. It's really helpful for us in terms of developing our own scientific working group around this topic, but also just inspiring to see what you've been able to do with it. So I think we can open up the floor to any questions or comments from anybody.
I can. Oh, go ahead, Mike.
Oh, sorry. Thanks a lot, everyone, for coming to speak to us. Yeah, as we're starting off, it's really great to learn from those who have already been forging this path for some years, and a lot of the lessons you learned. Like I think we've already, or I'm sure that we're already taking notes and adapting accordingly. Um, but your comments about engaging local community partners, um, and then, being a bigger challenge than maybe you anticipated because there is no empath. I'm sure if empath has the vision to do something new in Western Kenya, it's just you just use the word empath and like doors open, people are take note. There's a lot of interest, stakeholders come to discuss, and it's not like that probably in Indiana. So, but I was wondering, what would you say are the main barriers to engaging partners, or how is it different in Indiana compared to, if you were going to start out in a new part of another country? Just so that, I think we've started to do this, but would like to hear from your experience. What would you say is the biggest challenge?
I found honestly the one of the biggest challenges. The community partners have been great to work with and are super inviting and easy to have conversations and find common ground. I found the biggest challenge how to partner with the academic partners and not it definitely feels like there's turf and there's a lot of skepticism. Why are you guys are global health people? Why are you here? This is the area I'm collaborating in, and this idea of, well, let's all work together, and like we're not trying to take anything. We can find gaps, and we want to collaborate, and this our focus is collaboration in Western Kenya, and that's how we've been able to succeed and do what you say, where you just can move fast, right? We kind of want to build that model for collaboration here, but it took 30 years to build in Kenya, so it's not going to happen overnight here. And so I found it to be honestly to be taken seriously by the academic investigators here has been my biggest challenge, is because they really see us as like, you guys are global health people. You're not
They
Indiana
don't.
health equity people.
So they don't respect your track record, or is it that they feel threatened because you're sort of saying that maybe there are things that you and your partners could do to enhance the health of the community, and that's real threatening.
I think it's the threat. I think they feel threatened and just feel like that it's their space and they're the experts. And they are. And we try to come at it as you are the experts. We are new, and we want to understand how you think we could kind of add to this. But I think there is I've sensed some skepticism. I don't, Michael could chime in as well, but it's felt like we've really had to just like stick it out, and which is what we do, right? Like that's why we don't develop this on a project or a single funding stream, right? Even though we didn't get the CTSI funding that we hoped to, that would really take the academic piece to the next step. It's not all focused on just that funding. And so we're trying to develop a long-term partnership and program rather than just like a focused project.
The short term, yeah. Michael, do you have anything to add on there?
Well, as Laura was speaking, some of that skepticism, as Laura said, I think is healthy. We hear a lot about helicopter research in global health, and it happens too in Indiana, right? I mean, one of the things we've heard a lot from community partners is, you academics, you come around all the time. Every few years, we have another group approaching us, and then we, write a grant, and then they disappear. And so I think, making sure that we're sort of upfront with our approach for developing and going deep with partners, rather than going broad. I think that's been the empath kind of model, is right. We really focus on relationship building and developing the partnership and the sort of ecosystem of trust and relationships from there, which projects sort of develop and go. But I think a lot of the issues with parachute research coming in and out, we see too in Indiana, and so it's using RI as really a platform to talk about the importance of building those relationships, building that trust, sort of doing all of the things that create a good environment for sort of community engaged work.
And I will just add, I think that's why we wanted to start with rural health, because a lot of our health is rural, but we over this 2-year process ended up finding just we have to go where we have momentum and where the conversations are easiest, and that's why we're kind of focusing in this newcomer immigrant health space with the intention of learning a lot and hopefully being able to have the bandwidth to focus in rural health more. But also it's a bandwidth problem, right? It's having 2 robust partnership and projects going on in 2 hubs is a lot. The one already takes a lot of focus. So
yeah. Raina, did you have something you want to say?
Yes, Mike asked a lot of what I was trying to ask as well. I'm really intrigued because for those of us who are in Alabama, health inequities are front and center. And so the same principles of work we're doing in low middle income countries apply to the resource limited settings right here in our backyard, so to speak. So I had a specific question, and this is partly inspired by some of the work I'm involved with called Harambe. And we started in Seattle, and we're trying to get a footing in Birmingham, Alabama as well. And, this is a community academic, community-based research partnership. So we're very proud of it. But one thing, Laura, that we work with just like your newcomer health, we work with the health boards for these East African immigrant communities. So the Somali Health Board, Eritrean, Ethiopian, Congolese Federation, these sort of immigrant country-based in-group entities. What we haven't had are so these are sort of led, our partners are from those countries, but we haven't had partnerships from those countries directly. I hope that point makes sense. So I'm really intrigued, Laura, that, here you're working with Haitian Americans or Haitian immigrants in the US, and you're trying to connect Kenyans in Kenya with that group. Could you say a little more about what that bridging and connection has been like? You said, like, you and Michael don't want to be the facilitators in some way, like you want to totally remove yourself. So what does that mean, and how could our Harambe project learn to, do that for our work?
yeah, I guess I don't think we want to remove ourselves. We have to be a bridge in some way, right? But we don't think that the bridge is enough, right? I think that that connection is what we're trying to show could fuel the innovation. And so we're in the process of trying to figure that out, right? Because just the geographic distance is a big problem, right? And you don't want to a lot of these planning grants, and I just spoke at University of Maryland as well. A lot of the grants are focused on traveling to create partnerships. And that's so important, right? But you got to make sure that the next steps happen. And so I think now that we've already funded several partnership creations and traveling to create these partnerships, now I think any funding needs to look at how do you make sure the project's moving forward with the kind of continued presence of both sides to create that reciprocal piece with some virtual components in there.
Yeah, I was asked, Chiri, can you speak about sort of the experience of the Kenyan team in interacting with these local organizations from Indiana or the Haitian organizations? I think you're muted.
Sorry, yes, it just noted that was muted actually. Yeah, as Laura mentioned, this is at the initial stages that we are working on having these teams just work together. But we've seen the teams from Indiana come to Kenya just to have a feel of what exactly this looks like, with the hope also of trying to imagine a similar context back in Indiana, and with the hope that also the team from Kenya can have a feel of how the Indiana setup is, and as part of this co-creation, co-development, then the team can be able to work there, evaluate the whole model together, and the learnings that they come out of it can help to continue improving that relationship, improving that the model that they're developing as a team. So as we are envisioning, and as we work through this process, our hope is that this is the initial stages that we are working through this learning. Mistakes that we make become part of our learning process, and and grow through that process.
Thank you so much.
I have a
And I
question.
should say for Cherry, just quickly, she wasn't in the team. Her focus is NCDs. So she's not on the MNCH team. So I'm sure got to meet our team that came, but she didn't get to participate in those workshops just because it was, and we all have to maintain some focus as well.
Yes. Sorry, it looked like there were
wanted
a few.
If I could, I don't see any other hands, but I just wanted to ask Cherry, I'm not sure if you have how much you've worked in the US yet in your career, but can you speak to what would it mean for you? I think Laura just said you're an NCD expert. So, how would that advance your work at Ampath if you were suddenly, in charge of a program on NCDs in the US? Tell us, I just want to understand your thoughts about that. Like, how is that aligned with your own career?
Let me give an example, and being also an awardee of one of the planning grant that we had in the CTSI program is we have a setting in Kenya where we have our people living with HIV aging, and as they grow older, we do not have geriatric as discipline that is taught and expertise for that. And one of the things that we looked at is how can we build capacity for geriatric care for our HIV, for people aging with HIV in Kenya, for example. And as part of that planning grant and building relationship, we had a geriatrician come from the US, come to Kenya, look at what we have in our setup, how our healthcare system is set. And with that, looked at our, patient flow in a clinical care setting. Additionally, we had our Kenyan clinical care lead, and that's a day-to-day clinician who offers care for our patients living with HIV here. Travel to Indiana and shadow a geriatrician and also shadow an HIV clinician to look at how the setting is in offering care, offering geriatric care for older people living with HIV. There is the component of referrals. I see the HIV patients, and then for geriatric care component, I refer them to a geriatrician. And one of the things that we co-thought together is, if we build capacity for our primary care clinicians, our HIV care clinicians, to offer geriatric care to a certain level, especially the screening component, might allow us identify issues early enough before we actually, send them over to a geriatrician out there. And those are some of the things that we are still working on right now, building, from that, co-developing the tools that are context specific. Of course, there are tools that are used in high income countries, but the ones that now focus on the Kenyan environment, or an LMIC environment. So those are the tools that we are building now and trying to figure out whether to have a geriatric clinic with the HIV clinicians who has been trained or rather who has capacity to assess patients using these comprehensive geriatric assessment tools, can have all clinicians who are seeing older patients use those tools, assess the patients, and then manage what they can be able to manage and refer those ones that are necessary for that matter. So it's a field that I see not me benefiting being in the US, but I see also a US faculty member benefiting from the knowledge as well that we are learning from here, that we do not need too many geriatricians to take care of, aging population living with HIV, but rather we can build capacity for this community, for these care providers to still offer this care at a, certain level or to a certain level before you need that specialist care.
That's great. It really sounds like a bi-directional process, wherever they can learn from you what you know about task shifting and having, lower, lay health workers and others really, and training primary physicians to do some of these things that would have gone to specialists, and, and then you can learn from some of their tools and things that they've been using in Indiana as well. So I think it's a great example. Thank you.
I have a quick question if we have time.
Please go ahead.
I thank you all. This is really very interesting, and I'm so impressed with the work you're doing and have followed Empath for quite a while. I'm particularly interested in their work with community health workers. But my question is just how in this effort now, are you negotiating the dynamics around funding? And I assume that the funding is all coming from US-based grants. And I assume that creates a certain kind of power dynamic that is sometimes difficult. If in my experience, it has been.
Agreed. Anyone want to speak to that?
Maybe I'll let Sherry speak first.
I was going to let you, I was going to speak and let you just put a rejoinder in that, Laura. Yes. One of the things that I know funding is often an issue, especially from a resource, because it's already a resource limited setting. But the relationships where we've all had this mutual, and we see a mutual benefit from it. It could be funding that is coming from, the US-based institution, but it is also the learnings and the opportunities for our students to learn, the students from North America, the researchers who are able to also co-lead, co-develop, and build from these projects or build from this relationship to grow their careers is one of the things that you gain without looking at just funding only. Another thing is the trust in having the local leads in a way that you have the leadership within the local institutions, identifying the needs. They're the ones who are leading in determining what are the priority areas. And it's not then the funder who's coming in with the money and saying, now this is my priority and this is what I want to deal with, but rather these are our priorities and this is now what we want to co-work and co-lead together. Maybe Laura, you could add, and Michael as well.
Thank
Yeah,
you.
I mean, it's been such a difficult time, and it's created a lot of really hard emotions, and definitely feel like we're disappointing our Kenyan friends. And so I think that this, if you have to look at some silver lining, which there isn't a lot, is that we do have this like infrastructure in Kenya that is able to um, um, leverage beyond US grants and look to European grants, because we have shifted the prime of many of our grants from a US prime to a Kenyan prime, and created that expertise in Kenya, and Kenyans then have the ability to apply for those, and we will support them in that process and work with them on that, because it's so important, because we want all the work to continue. And so it will open that opportunity, and we've already been doing that, and have some investigators that can access grants in Europe. And then we are able to lean on all of our foundation grants that we've always used to fund our care program. But for the most recent hit to research, it's hit the Kenyan investigators, the Kenyan staff, and the North American investigators really bad. The hit to foreign aid, really, not much of our USAID funding comes back to North America anymore, so it was a hit really centrally to Kenya. And luckily we were reinstated on many of those, but it's all going to happen again. And so we're in the planning process to make to figure out how to support those patients. But I can say that since we all have really deep relationships, that I haven't really felt a lot of like my Kenyan colleagues have been like fabulous, and they know that we're like equally heartbroken. But I will say there is a power dynamic, because I can always just jump into work at the hospital here, right? And my Kenyan physician colleagues can do that too, with an income hit, but the research and care staff, like it's devastating what's happening.
Yeah.
Yes.
Thank
Thank
you for sharing that. I think, yeah, we're all feeling that very deeply. So this is a great conversation. I'm sorry that we have to wrap it up here. I hope we'll continue the dialogue, and we will be, sharing materials from this talk and our future seminars, and hope that we can continue to work together to develop this kind of work, which I really think is kind of the way forward at this point. So thank you very much to our speakers. We really appreciate you sharing this with us. We're inspired by you, and we wish you the best. Thank you. So
Thank
Emily,
you.
anything else we need to do to wrap
Thanks.
up, or I think we're good now. Yep. Okay. Thanks, everybody. Have a great rest of your day. Thank you.